We are live.
Good evening, everyone. Welcome to the refractive surgery module, lecture 487. The topic for today is bioptics. The moderator for the session is Dr. Kanika Bharadwaj. She's done her MBBS from Mohan Kumarangam Medical College, Salem, followed by DMB Ophthalmology from Eye Care, Noida. She has also completed a fellowship in cataract refractive surgery from Center for Sight, Dwarka, and is currently associate consultant here. Ma'am has been involved in DNB training and PG students. She is a recipient of multiple awards like the Best Video, Best Paper, Best Poster. Also, the Young Researchers Award for her thesis. She has multiple publications on cornea, cataract, and refractive procedures in various journals. Welcome, ma'am. Fine. I would also now like to introduce the chairperson for the session today, Dr. Swapnali, ma'am. She's done her MBBS from Guwahati Medical College, followed by MS Ophthalmology from Regional Institute, Guwahati. Ma'am has completed her fellowship from prestigious LVPI Hyderabad, followed by a 5-year consultancy there. Ma'am has actively promoted and pioneered corneal transplantation at Lion Eye Hospital at Guwahati. She was the first transplantation in North Bengal at North Bengal Eye Center, Siliguri. Ma'am has also been awarded G. Sita Lakshmi Award at Shankar Netralaya, Chennai in 2012 for ma'am's community work in corneal blindness prevention. Currently, ma'am is the head of Institute of Ophthalmic Sciences at AIG Hospital, Hyderabad. She's attended and delivered various talks at numerous conferences and also organizes an annual CME at her present institute since the last 3 years. Welcome, ma'am.
Thank you so much.
Finally, I would like to introduce the speaker for the session, Dr. Ameeta Koul, ma'am. She's done her MBBS and MS from Jammu Government Medical College. She has completed a fellowship from Rajiv Gandhi University of Medical Sciences, Bangalore. Ma'am specializes in cornea, cataract, and refractive surgeries. And also, she's been trained at Narayan Netralaya, LV Prasad Institute, and Shankar Eye Foundation. She has more than 11 years of ophthalmology experience, and currently, ma'am is a senior consultant at Center for Sight, New Delhi. She has over 20 peer-reviewed publications and has delivered lectures in national and international conferences. Welcome, ma'am.
Thank you so much, Garvita, for the kind introduction.
Ma'am, please share your slides, ma'am, for the class, ma'am.
Yes, please. Can you see my presentation?
Yes, yes, ma'am.
Okay, great. Good evening, all. It's my privilege to be presenting with Dr. Swapnali ma'am as chair, and an absolute pleasure to have Kanika moderate this session. Without further ado, since we are already late, we'll start the discussion on bioptics, combining the best of both worlds. Now, what is bioptics? Bioptics is defined as the sequential association of surgical approaches involving two different optical planes, the lens and the cornea, for correction of high ametropia and post-surgical refractive surprises. As of today, the term has expanded to encompass phakic, pseudophakic, and clear lens extraction cases, combined with several forms of corneal refractive procedures. The term bioptics was first introduced by Dr. Roberto Zaldivar in 1994 when he implanted a posterior chamber phakic IOL, followed by a secondary LASIK for the correction of extreme myopia. As of today, basically what happens here in bioptics, I'd like to give a bit of a background. The eye actually offers surgeons two distinct planes, the lenticular plane and the corneal plane, on which to engineer refractive improvements. Sometimes, in cases of extreme ametropia, correction on just one plane may be insufficient to achieve a clear vision, or it may be associated with a poor quality of vision because of maybe smaller optical zones or sometimes larger ablation depths. Bioptics basically provides customized way of treatment in these patients so as to achieve predictable and reliable post-operative outcomes. It presently encompasses use of an IOL intraocular implant followed by a cornea-based procedure for refractive errors that cannot be corrected only by one procedure. In addition to achieving near emmetropia, in cases wherein we have extremes of refractive error, bioptics also actually aims to refine stability and predictability of refractive correction, conserve corneal prolate sphericity, thus limiting the optical aberrations, and maintain large optical zones in order to achieve optimal quality of vision. Now, how are large optical zones possible to be maintained? It is so because of the optic of the IOL and the effective optic zone following LASIK. They both diminish in diameter as we do increased levels of myopic correction. So we are actually able to maximize the optical zone of each by doing both procedures. Of utmost importance in any refractive surgery to achieve desired outcomes is patient selection and a preoperative workup. So a patient should be over 18 years of age with a stable refractive error and suitable for both component procedures of bioptics individually. As majority of patients undergoing bioptics are high myopes, regular posterior segment evaluation is advised. Preoperative laser of pathological peripheral retinal degenerations is recommended to reduce the risk of postoperative detachment. The detailed inclusion and exclusion criteria are similar to other refractive surgeries. Age more than 18 to 21 years, stable refractive error, anterior chamber depth more than 2.8, less than 4 central corneal thickness more than 500 microns, and iridocorneal angle of more than 30 degrees, endothelial cell counts in excess of 2500 up to 3000 per millimeter cube, white to white of more than 10.8 and less than 13, residual stromal bed thickness of more than 250 microns, preoperative keratometry between 34 and 48 diopters, any intolerance to contact lenses, and an adequately counseled patient who has realistic expectations. These are all inclusion criteria. And exclusion criteria, as we know from our refractive surgery practice, patient whose age is less than 18 years, central keratometry more than 47.2 diopters, larger pupil sizes in excess of 7 known cases of corneal ectasia, known patients of glaucoma, uveitis, or any retinal or macular pathology, patients of corneal degeneration or dystrophy, patients having severe dry eye disease, collagen vascular disorder, any autoimmunity, any patient with a visually significant cataract or one-eyed patients, and pregnant or nursing mothers are other exclusion criteria. Now, going on to classification of surgical techniques of bioptics, we'll first talk about deferred bioptics. This procedure was introduced in 1995. It involves a phakic IOL implant followed by LASIK after an interval of 1 month. It is the most commonly performed technique owing to a predictable refractive outcome and safety. Limitation of this procedure is the possible IOL endothelial touch or IOL decentration during LASIK flap creation. In addition, anisometropia and reduced visual acuity during the interim period between the two procedures may limit the patient satisfaction. The general results of deferred bioptics are favorable. 85% patients usually get to within 1 diopter of emetropia, and there have been no incidences of visual loss after the second surgery reported. Then there is something called as the ARS or the adjustable refractive surgery. The concept of adjustable refractive surgery was introduced by Goel in 1990, wherein the LASIK flap was created immediately before the phakic IOL surgery, but not lifted. Thereafter, we waited for an interval of around 2 to 4 months. This was done to allow for refractive stabilization. And then this was followed by lifting the previously created flap for residual refractive correction. Now, this technique avoids the risks which are associated with creating a LASIK flap, as in deferred bioptics, after intraocular surgery. However, repeated flap handling may be associated with an increased risk of epithelial ingrowth. ARS avoids the risks which are related to the sudden increase of intraocular pressure with the microkeratome suction ring, such as IOL endothelium touch, lens decentration, etc. Again, this procedure has the advantage of 100% patients getting to within 1 diopter of emetropia. And again, like deferred bioptics, no incidence of visual losses after the second surgery, and only 1.2% of endothelial cell loss at 28 months. Then there is something called as simultaneous bioptics. Simultaneous bioptics was next introduced in 2005. It involved a phakic IOL implantation followed by immediate corneal laser ablation. Now, it had the advantage of being a single day procedure. There was an immediate visual recovery, and it was more cost effective to the patient. However, the refractive predictability in this procedure is poor because there are a lot of complicated calculations involved. And the longer surgical procedure will always be associated with a higher risk of complications in this. Then there is something called sequential bioptics. Sequential bioptics is actually quite similar to simultaneous bioptics. However, a gap of 12 to 24 hours is allowed between the two procedures. This procedure avoids repeat flap manipulation. There are no flap-related complications. The intrastromal femtosecond incisions are stable and associated with less incidence of dry eyes as compared to the microkeratome ones. Long-term efficacy and safety of this procedure is not really known, and this procedure is again fraught with possible IOL endothelial touch or IOL decentration. However, the proponents of this procedure claim that all patients will achieve a refractive endpoint of around plus minus 0.5 diopters within emetropia. It is important to note that ICL and LASIK power calculations are more challenging with sequential bioptics method. Now we'll have to use an estimated keratometric value and theoretical refractive power post LASIK to give the patient a phakic IOL. The factors to consider would include the distance to the vertex, the astigmatic induction from the clear corneal incision, which we may give the patient when we are putting in the phakic IOL, and any internal astigmatic modifications of the ICL itself. So, as we continue to improve our techniques in preparing the perfect cornea to match the IOL we implant, we might see an improvement in the quality of vision. Then there is something called as reverse bioptics. Unlike conventional bioptics, in this reverse bioptics, a corneal ablative procedure is done first. A secondary procedure, which comprises of either a phakic IOL implantation or a lens exchange, is undertaken after an interval in cases who have got regression or an incorrect treatment of refractive error. This technique minimizes chances of haze and ectasia following repeat corneal procedure. There is also a symptomatic reduction in nighttime halos with large optic diameter lenses. Surgical incisions which are performed during the second procedure may induce astigmatism in excimer laser treated cornea. So this is one downside of this. Reverse bioptics is typically unplanned, as in we do reverse bioptics for our patients. It usually happens in patients who have previously undergone a corneal refractive procedure and then come back with a regression and request an enhancement, but maybe subsequently poor corneal surgery candidates. So we take them up for a phakic IOL if the refraction is stable. Unlike the IOL power calculations for cataract surgery, posterior chamber phakic IOL calculations are less dependent on corneal refractive power and less affected by preceding corneal refractive surgery in reverse bioptics patient. Also because posterior chamber phakic IOL calculations are partly based on subjective refraction. So reducing myopia provides a more accurate calculated posterior chamber phakic IOL power. And this in turn could lead to a larger optical zone along with a diminished glare and halos in reverse bioptics patients, which has been shown in studies that it does happen. Patients who undergo reverse bioptics, as in a delayed posterior chamber phakic IOL after doing an excimer laser, usually report that their halos and glare have come down and they feel better visually. A thinner posterior chamber phakic IOL implant would obviously be less likely to contact and abrade the anterior crystalline lens theoretically, which may cause a decreased risk of anterior subcapsular cataract formation, which anyway nowadays we don't see much. With this procedure, all patients will achieve a refractive point of being within half a diopter of emmetropia. This is already proven in a lot of studies. In addition, the safety index is 1.4 and efficacy index is around 1 for this procedure. So efficacy index is mean post-operative uncorrected distance visual acuity by mean pre-operative corrected distance visual acuity. And safety index is mean post-operative corrected distance visual acuity upon mean pre-operative corrected distance visual acuity. Now there is something called as series bioptics. Series bioptics is conic intrastromal relaxing incision bioptics. This technique of conic intrastromal relaxing incisions was first introduced in 2007. So the first step in series bioptics is creating oblique intrastromal corneal incisions with femtosecond laser to treat corneal astigmatism. And this is followed by implantation of posterior chamber phakic IOL after 12 to 24 hours. There are no flap related complications because there are no flaps. The intrastromal femtosecond incisions are stable. They cause no damage to the epithelium. They are associated with less dry eyes. Greater stability is proffered with the bevel inverted side cut. And long-term efficacy and safety of the procedure is not known because we haven't gotten around to doing this procedure a lot. I would like to invite comments from our moderator and our esteemed chairperson at this point of time if they want to add something to this, if there are any other procedures that they know of and they would like to add to it.
Sometimes we can do something called trioptics also. That is one thing I can add. I think trioptics is like 3 procedures added to one eye. This includes having a PRK and C3R done together for a keratoconic eye, followed a month later or 3 months later by a phakic toric ICL. So I don't think beyond that there are any other names of any procedures that we know beyond this. Dr.
Right,
Kanika,
ma'am.
do you have anything to add?
No, ma'am, I was also about to say the same that a topo-guided PRK at first sitting
Hmm.
with or without C3R, depending on how the keratoconus stability is, if it is progressing or not. And
Yes.
later on, we can go for a toric phakic IOL to correct the. Sometimes we can get customized ICLs also for some who have very high irregular errors. So
Yes. Yes.
that
Yes.
can also be done with, after collaborating with the company, they do make customized ICLs also for irregular astigmatism as well.
True. And that can be done for optical penetrating keratoplasties also, where they come up with irregular astigmatism. There also, I think we can combine these kind of procedures. Maybe not go for a femto, but go for a surface laser, and later go for a customized phakic ICL.
Right, ma'am. I have discussed these in detail in a few
Okay,
slides. I'll be
okay.
discussing
Then
the
let's
outcomes of
proceed.
surgeries.
Yeah,
Yeah,
then
ma'am.
let's proceed.
So, now most corneal and intraocular procedures can be combined successfully, such as intrastromal corneal ring segments, which we were just speaking about, ma'am, with excimer laser like PRK, and femtosecond laser-assisted procedures like CD with either phakic implants or pseudophakia. So the different procedure combinations and their reported summarized outcomes, I'll be just discussing in the upcoming slides. Um, Now, there was this prospective trial which evaluated safety, efficacy, predictability, stability, complications, and patient satisfaction. That is something called as the artisan phakic IOL implant. That was followed by a LASIK for the correction of high hyperopia. The study included 39 eyes. They had a mean preoperative spherical equivalent of 7.39 diopters plus minus 1.3 diopters, and a cylinder between 0 and 4 and minus 4.25 diopter. Now, the artisan iris fixated phakic IOL for hyperopia was implanted, and then after 6 to 8 months, they did the LASIK. The best corrected visual acuity, the UCVA, refraction, endothelial cell loss, endothelial morphologic analysis, and patient satisfaction, everything was recorded. And the follow up in this study was around 12 months. This study found that at 1 year, around 94.9% eyes were within 1 diopter of emetropia. And there was a statistically significant decrease in best corrected visual acuity after phakic IOL implantation, but this effect was in turn corrected after LASIK. So the mean, they also found that the mean endothelial cell loss was around 10.9%, but morphological analysis suggested there was no additional damage caused by LASIK over that which was produced by the phakic IOL surgery. And in this kind of a procedure, overall patient satisfaction was quite high. So the authors concluded that the combination of artisan phakic IOL implant with LASIK had safety, predictability, and it effectively reduced high hyperopia. The only problem was that in 1/3 of the eyes which were implanted with this IOL, there was a loss of 1 line of best corrected visual acuity, and halos and glare were a potential problem. Then there was a surgical combination of angle supported phakic IOL followed by LASIK. This was a non-comparative interventional case series which was undertaken on 24 consecutive eyes of 12 patients. They had a preoperative spherical equivalent between 9 and 26 diopters. Now, implantation of an angle supported phakic IOL was done as the first surgery. Then LASIK was done at least 6 months after this surgery, once the stability of topography and refraction were both proved. So, main outcome measures in this study were uncorrected distance visual acuity, BCVA, refraction, applanation tonometry, endothelial cell loss, and minimum follow-up for 12 months after LASIK was one of the final endpoints. The authors in this study found that the mean spherical equivalent refraction decreased from 15.17 minus 15.17 plus minus 5.15 diopter before the phakic IOL implantation to minus 1.33 plus minus 1.18 diopter after phakic IOL surgery. This was huge. And after LASIK, it came down to 0.01 plus minus 0.53 diopters 12 months after LASIK. So uncorrected visual acuity after PIOL surgery was 0.3 0.39 plus minus 0.12, increasing to 0.65 plus minus 0.23 12 months after LASIK. So there was basically an increase in to 20/40 or better. And with it was to the extent of around 17% after phakic IOL surgery alone. But once they did the LASIK, they found that the effects were very good for at least 84% patients. And at final follow-up, spherical equivalent was within 1 diopter of emetropia in around 91.7% eyes. So these were very good results. And in 75% eyes, they were within 0.5 diopters. So the astigmatic component of the refractive error was also very well corrected after LASIK, and that so that at the final follow-up, the mean endothelial cell loss was also again 4.88% only. The study actually found no statistically significant differences between endothelial studies like cell count, hexagonality, or CV before LASIK and 12 months after LASIK. So they basically suggested that there was no corneal endothelial damage happening by LASIK itself. And since no sight-threatening complications occurred throughout the follow-up period of 12 months, they concluded that this combination was safe, effective, predictable, and stable for the correction of high myopia. Then there was this prospective non-randomized single surgeon study, which was done on around 48 patients, 76 eyes. They underwent an angle-supported phakic IOL implantation with surgical PI, followed 2 to 3 months later by PRK to correct the residual refractive error. Now, in this study, what they used was a mean defocus equivalent and mean astigmatism. The authors found that 8 months after the PRK, the mean spherical equivalent was as less as minus 0.08. And mean uncorrected visual acuity was 0.7. So safety index was good, efficacy index was good. Only problems were the complications of recurrent iridocyclitis, which happened in only one eye. There was a transient ocular hypertension in 2 eyes, and one eye had undergone an incomplete iridectomy. They concluded that angle-supported phakic IOLs and then adjustment PRK, it is again good efficacy, predictability. It has a good safety to manage large refractive myopic errors. However, the person who is doing the surgery, the surgeon, they need to be well versed with their techniques and they need to be able to do all the steps properly. Then this study was there, which evaluated the results of combining a posterior chamber phakic IOL with LASIK to treat high myopia or myopia with astigmatism. In this study, they had 2 arms basically. So 32 eyes of 28 patients were taken. They had either extreme myopia or they had myopia combined with astigmatism. And this was treated by implantation of a phakic PCIOL. Now, residual refractive errors were treated no earlier than 6 weeks after IOL implantation. That means once they did the phakic IOL implantation, they waited for 6 weeks and then they corrected the residual refractive error. They divided the patients into 2 groups. One group with a low refractive error was treated with PRK, and the patients with a higher refractive error, they were treated with LASIK. They found that with mean preoperative spherical equivalent refraction at 18.7 diopter, refractive astigmatism ranging from 0 to 3.5 diopter. In the LASIK group, they found the spherical ametropia range from minus 1.5 to plus 1.5 diopter and astigmatism from 0 to 1 diopter. And after excimer laser treatment, the uncorrected visual acuity improved in all eyes. Now, in the same study, when they evaluated for the PRK group, the residual refractive errors, again, were treated after 6 weeks of the minimum after 6 weeks of IOL implantation. They found that with mean preoperative spherical equivalent being same, 18.7 diopter, and astigmatism again ranging from 0 to 3.5 diopter, after excimer laser treatment, the spherical equivalent refraction ranged from 0.5 to 2.5 diopter. The uncorrected visual acuity also improved in all eyes after excimer laser treatment. They thus concluded that bioptic treatment of extreme myopia and myopia associated with astigmatism was safer and more predictable than other methods of treatment. Now, there was this retrospective study, ma'am, this is what you were talking about, that to evaluate the safety and clinical outcome of the Vision toric implantable columnar lens. for the treatment of residual refractive errors 6 months after sequential ICRS and collagen cross-linking in stable keratoconus. Now, this study examined results of a 3-step ICRS, cross-linking, and TICL in around 11 eyes of patients who had moderate to severe keratoconus. 2 procedures, the ICRS and cross-linking, were performed sequentially at an interval of 4 weeks in this study. And the toric ICL implantation was performed at least 6 months after the cross-linking. They found that the ICRS cross-linking, it induced a significant decrease in keratometry, which we already know it will. It also increased the visual acuity in the long run, reduced the refraction. No intraoperative or postoperative complications occurred for any of these patients. They therefore concluded that toric ICL implantation after sequential ICRS and CXL would be an effective and safe option for correcting high residual refractive error and also improving visual acuity to very good in patients who have moderate to severe keratoconus. Just quickly about this study, this was done on 12 eyes to check the safety, efficacy, and improvements in patients who underwent excimer laser followed by placement of angle-supported phakic IOL, basically kind of reverse bioptics to neutralize the regression or remaining error post-excimer laser. We have already spoken about this. They found that while the mean preoperative spherical equivalent before excimer was around minus 11.7 diopter, post-excimer laser regression, it was around minus 8 diopter in this particular group. And the results showed that there was an improvement in mean spherical equivalent up to minus 0.3 diopter, and 100% patients achieved emmetropia to within plus minus 1 diopter error. Safety index, again, very good, 1.4, and efficacy index was 1. Mean endothelial cell loss after IOL implant was around 8%, so less than 10%. The study concluded that despite mild pupil ovalization in 2 of the 12 eyes, and nighttime halos were reported to get better by patients, and reverse bioptics was a great fit if we were looking at correction of long-term regression post-excimer laser. Now we're going through bioptics for myopia, whatever we have heard till now, the combination of phakic IOL with excimer laser, which may be LASIK or PRK, is one of the most successful surgical approaches in bioptics. This approach is predictable and it's safe, owing to the deep anterior chamber of myopes, ease of laser correction of residual myopic error as compared to residual hyperopia, and ability to achieve corneal optical zone, which is wider than that of IOL optical zone. So majority of the studies demonstrate improved outcomes after laser enhancement. I've already spoken about this. However, it may not always be necessary to perform a laser ablation after IOL implantation. What we are trying to say here is in case the patient has an emmetropia, which is higher than what you can safely correct with a phakic IOL, we can consider a myopic LASIK or a PRK. Therefore, an ARS approach may be recommended because it avoids unnecessary flap lifting in such cases. Most complications are related to specific type of phakic IOL used. Most studies describe no significant endothelial cell loss, like we just heard. It's to a maximum of 10% and no more than that. And halos caused due to residual error appear to improve after large diameter optic zone laser ablation. Hyperopia is a limiting factor for implantation of phakic IOLs because of physiologically shallow anterior chamber in these patients. The phakic IOL correction in these patients targets residual myopic astigmatism because that is easier to correct with excimer laser ablation as compared to residual hyperopia. And most studies describe use of iris claw phakic IOLs in this subgroup of patients because it is contemplated to be remotest from angle as well as from the anterior lens capsule. Now, speaking about bioptics with crystalline lens exchange, this aspect has a significant downside of loss of accommodation and should preferably be used in presbyopic or very adequately counseled hyperopic patients. Hyperopic patients are more suited for this procedure owing to a lower risk of VR complications, limited efficacy of hyperopic ablation, and physiologically shallow anterior chambers. Now, several surgical visual rehabilitative alternatives are available for patients with non-progressive corneal ectasias, including toric phakic IOLs, intrastromal corneal ring segments, and surface ablations combined with corneal collagen cross-linking. Patients intolerant to contact lenses are especially suitable candidates for surgical intervention. ICRS or intacs are preferred in patients with high astigmatism prior to the use of phakic IOLs. Phakic IOL implantation after cross-linking should be done after stabilization of refraction and keratometry, as changes in these parameters can lead to a reduction of post-op visual acuity. Most studies usually recommend a 6-month gap between implant ICR and cross-linking and then phakic IOL for optimal outcomes. So nowadays the understanding is we can do ICRS and cross-linking in the same sitting, and then after 6 months we can go for a phakic IOL instead of having a sequential ICRS and CX. Routine follow-up after bioptics procedure should be done at day 1, month 1, 3, 6, and yearly thereafter. Follow-up visits again should include detailed ocular examination for uncorrected visual acuity, best corrected visual acuity, topography, slit lamp biomicroscopy for any flap-related complications, and as documentation, as well as documentation for the phakic IOL vault. As many of the candidates are high myopes, it is important to ensure regular posterior segment evaluation, even post the fact, to look for pathological myopia-related changes. Now, quickly going through the complications, we all know intraoperative complications which are related to laser-based procedures, incomplete and free flaps, buttonholing of flaps, suction loss, vertical gas breakthrough, intracameral gas bubbles, opaque bubble layer, limbal bleeds, flap tears, and epidefects. Late complications related to laser-based procedures, which can also again happen in bioptics: infectious keratitis, flap stripe, flap dislocation, DLK, PISK, central toxic keratopathy, epithelial ingrowth, dry eye, ectasia, overcorrection, undercorrection, or regression. Long-term complications again, ectasia, regression, overcorrection, undercorrection. Intraoperative complications related to phakic IOLs, not seen much these days, chipped or broken phakic IOLs, inverse phakic IOL, or damage to intraocular structures. And these are the late complications related to phakic IOLs: ovalization of pupil, UGH syndrome, cataract, raised IOP, chronic uveitis and inflammation, pigment dispersion, endothelial cell loss, corneal decompensation, dislocated or decentered lens, glare and halos, surgically induced astigmatism, and retinal complications. Now, bioptics is a viable treatment modality for patients who have high emmetropia with the magnitude of refractive error beyond the scope of any single specific refractive surgery technique. It recuperates acuity and quality of vision. Reverse bioptics with phakic IOLs or RLEs is also a predictable reparation for poor corneal surgery and should be preferred to laser retreatments to prevent a risk of ectasia. The paucity of comparative studies between different techniques makes it very difficult for us to conclusively determine the best possible combination of the available permutations. We can envision bioptics as the standard procedure for higher refractive errors, the only drawbacks being increased risk of complications due to two procedures being done, as well as the prohibitive cost. These are references. I acknowledge all these researchers and authors. Thank you very much.
Thank you, Dr. Amita. That was a very comprehensive talk on the subject. I may invite now Dr. Swapnali ma'am to comment on the presentation. Ma'am, your insights into the topic.
So yeah, very nice presentation. She covered everything, and especially the way she presented the studies was very interesting because it gives us an in-depth knowledge of bioptics. But there's one question I want to ask the speaker: that was there any study on the contrast sensitivity post these procedures at 1 year? Was that in any of the primary endpoints in all these studies?
So, ma'am, all the studies that I have quoted here, none of them had spoke about contrast sensitivity. All these studies, mostly they're done before 2010.
Okay. Okay.
So at that point of time, they were looking at major things post surgery, whatever major things they could find. They were more worried about endothelial cell loss, I felt.
Yes, yes.
And they were also worried whether how many of the patients are actually coming to emmetropia. Those were the major. So that is why the safety index and the efficacy index and all they made up at that point of time, just to check how much the corrected visual acuity is coming to. They wanted to show that it was really it was effective. As in related to vision.
So
yes,
if
ma'am.
we have
So
5 years data now, if they go through all those patients with a contrast sensitivity also, it will be very interesting.
yes, ma'am.
And
Yes,
also
ma'am.
the
Absolutely.
endothelial cell loss. So there are three things which are coming to my mind for this. First is that one important thing we have to see is the pupillometry, especially in the mesopic condition.
Right, ma'am.
Because we are going into larger ablation zones here, so we have to record that before surgery. Second, probably what you have already mentioned, the retinal condition. These are like high myopes.
Right.
So I'm an old timer. I would prefer to do a surface laser after the ICL rather than doing the femto or the plate thing. And third is the counseling. So these patients, the problem what I have seen is that once the first surgery is done, they are so excited that they really want to, jump into the second surgery. So here, as surgeons, we have to explain to them to have that waiting period, see the response, and then go for the next. Because once we touch the cornea, the entire
There is no
optics
turning back.
changes.
Yes,
Yes,
ma'am.
and we have to mentally prepare them for that. I think apart from that, bioptics, by and large, by default, also most of us are doing. We get patients from another place also who needs further treatment. So, Dr. Kanika, would you like to add anything to that?
Yes, ma'am. Like you said, firstly, like ma'am already said, Dr. Amita, that these studies are from before 2010. Actually, the newer version of ICL, which has the central aqua port, this was introduced only after 2007 onwards. So there are not much studies. Also, the safety profile has also increased a lot. So
Important.
definitely, with the newer generation of phakic IOLs available to us, the risk of complications has come down drastically, and the single procedure itself is very successful. I've seen patients in my clinic, and I've seen patients from other surgeons after getting operated who were wearing very high numbers previously, and now their number has come down. Like after the first phakic IOL procedure, their number has come down from a two-digit number to a, let's say, less than 3 or 2 diopters of myopia, and they're happy with that because they get to retain their natural accommodation, and for the little amount of myopia that's left, they also do not face a lot of difficulties with their near vision, so they are not too much bothered. But like ma'am said, there's always an option to go ahead with the surface ablation procedure. Recently I met a guy who in the first sitting, he had a high myopia. He had around minus 10 diopters of myopia in one eye, and the other eye had around minus 8 diopters. His corneal pachymetry was a little on the borderline side. It was somewhere around 560, 550 microns, considering the number he had. So he underwent a lenticule procedure. He underwent a smile and was intentionally left like undercorrected. So one eye was completely corrected and the other eye was undercorrected, and the person was able to manage his day-to-day activities with the amount of undercorrection. It was something a sort of mono vision kind of a thing. Although in young age that doesn't matter much because the near vision difficulty is not that high. So now this guy had come again to say to go for a second procedure. He said, can I get the remainder of my number removed? And so then when we checked his data and everything, the only option that was suitable for him, because of the corneal manipulation already done, was a phakic IOL. So we did suggest that if you want, even for a less residual error, maybe in the range of -2 or -3, we can go ahead and implant an ICL in your other eye. He's still contemplating about it. He's not very uncomfortable at the moment. So he's managing, but there are certain patients who want to jump into it right away, and some who are able to manage because their disability has come down. The more stronger people who are inclined towards this are the ones with irregular corneas, especially those who have had history of keratoconus in the past, who have had C3R also done in the past, and now are not happy with the quality of vision. Those people I have noticed are, they want to search for something that can improve their vision further because they are not very happy with their glasses. It's not just the independence from glasses, but the quality of vision that they are affected. And that's where the concept of intacs and added phakic IOLs comes into play. So, generally, bioptics in our clinics, we do not go ahead straight away for higher errors. We do give them an option that if they can manage with a lesser correction, and for people who are still interested, generally we prefer going for a phakic IOL first, and if there is any residual error, probably 3 to 4 months later, we don't even wait for like 1 or 2 weeks or so. We wait for a solid 3, 4, 6 months, let the patient adapt to the lens. And then if there is any residual error, then a corneal procedure in the second setting. That's what commonly I see in my clinic. Of course, my experience is far less than ma'am. Dr. Swapnali, ma'am, what's your experience? How many patients you think require bioptics in your clinics that turn up to you?
So Bioptics per se maybe around 5%. So five. If you take the keratoconus patients, it might push up to around 10%, but not more than that. I think the most challenging are the high hyperopes because you have so less to give them, and you
True, ma'am.
have to explain the loss of the accommodation. If they are in their late 30s, they are okay with that. But the younger ones, it is very difficult to counsel. So I have done the clear lens exchange in maybe 3 patients who were around their late 20s. And I was just hoping that they don't come with a refractive surprise where I have to do a laser procedure on
Second.
the cornea. Yeah. So 2 of them did well. The third is due to come. So I was about to ask that because I don't have much experience of bioptics in hyperopia.
Hyperopia.
Yes, yes. So if you all can shed some light on that.
Ma'am, I've seen hyperopes generally tend to accept their disability. I don't know. I have seen this. There are some more or less times they are amblyopes also. Their vision is not very perfect right from the beginning, and they tend to accept their disability more. They are even okay with their thick glasses, and they are somehow managing. So any option given to them, they very readily accept it. That's what I have seen in my clinics up until now. And even if they are not getting rid of the glasses entirely, or even if the correction is not giving them a very sharp, precise vision, they're just happy by the removal of those thick glasses that has been, reducing their peripheral field of vision. So hyperopes generally I've seen are not that complaining. The myopes, definitely the high myopes are the ones that constantly desire for more because they are used to having that kind of fine vision for both distance as well as near distance with glasses and near without the glasses. So the loss of accommodation part also is more pronounced and more unacceptable to the myopes I have seen.
And the myopes have more mesopic pupils.
Yeah, yes, ma'am.
So we have to be very careful with them. That is sure. Dr. Amita, any experience with high?
Ma'am, none with hyperopia per se, because like you said yourself, the kind of old timers. I don't like to mess with hyperopic patients much. If they are accepting their corrections, good for them. And I would like to counsel them to be. I have never, tried what you've just told that you have tried and the patient is due to come and you would like to. I have never tried it. I had a patient, I would like to differ on one point with Dr. Kanika that she said they usually accept it. Yes, they do. But nowadays, with so much of marketing about LASIK and PRK, I saw one patient, he was plus 4.5 diopter in both the eyes, very keen to get his glasses removed. I have never seen a keener patient for refractive surgery. And he told me that, do something, anything you will do, even if it gets complicated, I'm ready to accept it. I'm like, no, it doesn't work like that. And then he was closer to the presbyopic age. So I was all the more not inclined to do something for him. But one more thing that Kanika said that in Fakey IOL's Aquaport was not there before. We were talking about that, and now it is there. Actually, in 2007 or 2008 only, we started with those Fakey IOLs, and uh, after 2010, I have hardly found any studies. Although they could have done studies about ICLs, Fakey IOLs with Aquaports, whether like you rightly said, they would not have to do the PIs then, and they could just go ahead with these ICLs and do a refractive procedure later and see where the myopes are landing in the long run. One is that, and the second is while you were discussing that how the how which what kind of patients we can take for, like I said in my presentation, it could be a lot of high emetropia patients who are not getting corrected and all, but it could also be for patients like who have an ACD of like borderline ACD. Suppose I had a patient who came to me with an ACD of just 2.8, and I needed to do a fake IOL, and the powers were like 12 spherical with say 3 or 4 astigmatic error, I probably, if there was a good corneal thickness, I probably would like to do a spherical ICL in that patient with the later maybe a PRK or a LASIK for the surface. I don't know if I'm right in thinking like that. Swapnali ma'am, I would want your feedback on this one because I have had a few patients like that, and every time the borderline ACDs come to me, it sets me thinking as to what is the right thing to do for that patient, whether we should implant toric IOLs with a higher astigmatic power or just give them a spherical correction as in phakic IOL first and then wait for some time and then do a surface ablation for them.
I would go with your second option.
Right, ma'am.
Yes.
So, Amita
Because
ma'am,
it is
there are
a
some Indian brands also who those there that manufacture phakic IOLs, and ICL has a certain criteria like in hyperopes and myopes, the minimum anterior chamber depth criteria is there. So mostly it should
right.
be above and beyond 2.8 for ICL. But there are certain Indian brands who tend to customize their phakic IOL thickness, and they are even providing customized phakic IOLs for anterior chamber depths less than 2.8, like the ones in the range of 2.76 or 8. Though
Right.
not very popular, and we have not pushed towards that yet, but yes, there are some
Yet
Indian companies
there are a
available.
lot of surgeons who are doing it, Kanika. You're right. A
Yeah,
lot of people are
I've
doing
seen
it,
seen
but
a
I
lot of
have never
people do it.
attempted to do it.
Yes. Same here, because it's
So
not
I
just
was
about
just
the anterior
wondering if
chamber depth. We need to prevent the endothelial damage as well. We can't just keep, stuffing everything inside the anterior chamber.
everything. Yeah, you need to
Naturally,
look at it. Correct. You need to look at the distance from the endothelium and from the anterior capsule. You don't want that thing touching anywhere. So that thing always kind of sets you thinking because these are all young patients. Like in young patients, you're doing any procedure. I'm still comfortable to an extent with phakic IOLs because I know they are reversible. I can just remove them. Hmm? But though not without repercussions all the time. But for a refractive surgery procedure, I always think 3, 4 times before I, fire the laser. So yeah,
true, ma'am. Choosing a patient for bioptics is not easy.
it's not easy.
And a very highly motivated patient and very well-counseled patient can be taken up irrespective of
Correct.
the refractive error, because they do have a lot of questions and a lot of expectations, and sometimes they do feel disappointed after spending so much. So it has to be decided very carefully. Like,
Right.
bioptics is not a very common procedure that we do on a daily basis. Dr. Garvita, do we have any questions in any of the platforms?
Hey ma'am, I can't see any questions on YouTube, and I think we have discussed the topic pretty comprehensively because even our audience is not any questions right now. I
I
just
think
received just
Dr.
one in the
Jyoti
chat
has
box just
asked a
now.
question. Dr. Jyoti has asked a question in the
Yes.
chat box.
Yes, just now the question
Yes.
is there,
Can
ma'am.
you please?
How does the patient counseling and patient expectation differ in cases of bioptics as compared to routine refractive surgery?
So, Dr. Amita, would you like to take that?
Yes, ma'am. Yes,
Yeah.
ma'am. I would love to take that because it is one of my favorite questions of all time. So it doesn't really differ. You just need to be more forceful in explaining to the patient what to expect. So if you would have seen through my slides, Dr. Jyoti, you would have seen in the uh, exclusion criteria I have mentioned, a patient who has unrealistic expectations should not be taken for a bioptics procedure. For that matter, any refractive procedure. Okay, so you'll have patients coming to you and asking, we need 6 by 5, we need 6 by 4. One of my friends got this surgery, got 6 by 4. Will I get 6 by 4? This is the patient you clearly steer clear of. Okay, don't touch this patient. They will never be happy with you, even if you give them a 6 by 6. So you have to first get the patient down to the ground of reality and tell them what we are expecting to do with this procedure. Put the facts in front of them and then let them decide, right, what they want to do. Especially in bioptics, I feel because it is two procedures, it's double the money involved, double the pain for the patient if you're doing a PRK, and then they might not be able to reconcile with the results because for you and me, it might just be statistics, but for a patient, It is about their vision and the quality of life they'll have afterwards. So unless they understand what they are getting, they should not be getting into it, and we should not be, offering the procedure at all. That is my understanding. Maybe I'm just being skeptical. I think Swapnali ma'am might want to add something.
Yeah, so for me, basically, for bioptics, I never counsel at one go. I explain, send the patient home, give time to think, and come back. I think a slow counseling before surgery for these patients is very important so that they can make up their mind and come back. And then one another thing which suddenly I remembered is that we usually get the astigmatism in very surprising areas sometimes when we combine procedures. So that also I think we should explain to the patient that spherical correction is still in our hands. Astigmatism, because these patients don't expect to get a zero point 0.5 astigmatism also. So we should tell them that this is something which might happen and it's a natural process. This can happen over time also. So what do you think about that astigmatism part also? Because I personally do that every time I do this kind of a combined procedure. Dr. Kanika?
Yes, ma'am.
So
Definitely, ma'am, I agree with you. And in our counseling, what Dr. Pooja is asking, in all of our counselings, we never promise the moon to the patient. We just say that we will try. We will try to give you as comfortable vision as possible. If not with one procedure, then two, probably at a later date. There is no hurry about it. You think on it very nicely, very clearly what your expectations are, and are you okay moving ahead with this, your financial constraints and everything. So in the counseling part itself, we do not promise everything. That is the one rule in refractive surgery that we follow, because these days every patient has a lot of expectations and they are so prone to getting exposed through videos and various surgeons claiming so many things
yeah,
that the
yeah.
patient has a supervision, superhuman eyes and this and that. So
Mm,
definitely not talk on those terms. We talk very simple, basic, scientific knowledge to the patient. We give them the choice. We do not force anything on the patient while we are counseling them. We give them their choices. And like ma'am correctly said, we give them time to think. It's never like कि आप आज आए हो, go get your surgery booked. It is always that you go home, you think about it, you read about it, you do your own research. We also give them leaflets and pamphlets and material to read so that
yeah.
they have a ethical knowledge of stuff rather than just googling around somewhere. So we give them those materials and we ask them to go home, think on it, read on it, come back with doubts, and
Mm.
if they're convinced, then on the second or third sitting probably, then we can go ahead and plan the surgery in their case. And again, every time we explain to the patient that what we are doing is to make your life more comfortable, but there's nothing that can be guaranteed.
Another thing we need to remember is to ask them how much of night driving they do.
Yes, ma'am.
Very
How
important.
active lifestyle
Yes,
they lead,
yes,
that is very important.
very important. I think we have covered mostly everything that we need to cover in bioptics. I'm actually looking forward to some new literature. There's a paucity of scientific literature. So, to know what are the long term consequences of these procedures, we have been doing them, but I think we have also from India to, gather some data and find out how these patients are doing in the long run.
Yeah, I think a lot of senior surgeons can contribute in that, ma'am. Maybe we should, get all our resources and data together and publish a scientific paper with all surgeons contributing their patients or bioptics, because everybody would have done some. I'm not
Yes. Yes.
saying it'll be a large, but it can be a good, case series.
So, I
That's
think we can
actually
wrap
very,
for today.
yes, ma'am.
Yes.
Thank you, Swapnali ma'am. Thank you for your precious time and your important comments on the subject. And it's our honor to have you here.
Thank you
Thank
so
you, Dr. Ma'am, for a beautiful presentation, very thorough, very uh, to the mark, and with a lot of references and everything. So we should definitely go and search for new references and newer studies as well, like ma'am said. Thank you so much, Dr. Garvita, for moderating this session along with me. I think let's call it a night and good night, everyone.
Thank you. Thank you. Thank you so much.
Good night.
Good night.